بسم الله الرحمن الرحيم. أنا دكتورة إيمان عبد الغني سيد، أستاذ مساعد روماتولوجي وكلينيكال إيمينولوجي، كلية طب جامعة اسكندرية، وهنقدم النهاردة محاضرة عن الأوستيو أرثرايتس. أول حاجة definition of osteoarthritis is the most frequent musculoskeletal disease that leads to functional decline and loss in quality of life. Clinically, the condition is characterized by joint pain, tenderness, crepitus, stiffness, and limitation of movements with occasional effusion and variable degree of local inflammation. Pain in osteoarthritis is frequently activity related, يعني is activity related. Constant pain and frequently became a feature but later in the disease. Pain in osteoarthritis is not simply attributable to structural changes in the affected joints, but the result of interplay between structural changes and peripheral central pain processing mechanisms. The epidemiology of osteoarthritis in the world, about 9.6% of men and 18% of women of age greater than 60 years have symptomatic osteoarthritis. What about the types of osteoarthritis? We have primary osteoarthritis, also called idiopathic osteoarthritis, where the cause of this type is unknown, and secondary osteoarthritis, and it occurs due to a specific cause like rheumatoid arthritis, other type of arthritis, trauma, metabolic causes, endocrinal disorders, congenital abnormalities. This causes the secondary type of osteoarthritis due to a known secondary cause present in the cartilage. ده الستراكشر اوف ذا كارتليج. هنا عندنا ده هو الارتيكولار كارتليج. ده الموست كومن بارت تو بي افكتد ان osteoarthritis. This is the articular cartilage. بعد كده عندنا هنا ده اللي هو الساينوفيال كافيتي، ده الجوينت كابسول with synovial lining aligned by synoviocytes اللي هم cells of the synovial capsule. This is the bursa، وده الستراكشر اللي هو بيبقى موجود outside the joint. This is the muscle and this is the end of the muscle which is termed the incisors, represents the site of attachment of tendons or ligaments to bones. This is called the incisors. But it's not the matter in osteoarthritis. The most important structural changes in osteoarthritis is damage to the articular cartilage. What is the risk factors for osteoarthritis, including age? Increasing age lead to osteoarthritis. Females are greater risk for getting osteoarthritis than men. Obesity, traumatic injury, persons with a positive family history, persons working in construction sites, healthcare setting, factories, farming, sports like wrestlers, cyclists, football players. This is risk factors for the occurrence of osteoarthritis. How osteoarthritis occur, or what is the pathogenesis of osteoarthritis? This is represent an interplay of different factors. Systemic factors like age, sex, ethnic characteristics, bone density, hormonal therapies like estrogen replacement therapy in postmenopausal women, maybe nutritional deficiencies, genetic factors, or other systemic factors. This increases the susceptibility to osteoarthritis. In addition to the presence of local biomechanical factors like obesity, joint injury, joint deformities, sport participation, the presence of muscle weakness, and this all determines the site and the severity of osteoarthritis. So the pathogenesis is an interplay of different factors like systemic factors and local mechanical factors. This represents the anatomical distribution of osteoarthritic patients with involvement of cervical spine, lumbar spine, الهاند joint including الدistal interphalangeal, الproximal interphalangeal, الfirst interphalangeal joint, الfirst metacarpophalangeal joint and the carpometacarpal joint, in addition to الhip والknee and foot joints. وده طبعا اللي برضو الهاند affection in osteoarthritis involving الcarpometacarpal joint of the sub and the proximal interphalangeal joint and the distal interphalangeal joint. What about the diagnostic criteria or how to diagnose a patient with osteoarthritis? We have knee osteoarthritis and hip osteoarthritis. Knee osteoarthritis diagnosed by pain in the knee, presence of osteophyte on radiograph, any one of the following characteristics: age greater than 50 years, morning stiffness not more than 30 minutes, crepitus on motion, presence of bony enlargement, bony tenderness, and palpable warmth. While hip osteoarthritis is characterized by pain in the hip and in addition to two of the following, including ESR less than 20 millimeter per hour, femoral or acetabular osteophytes on radiographs, and joint space narrowing. EULAR-based recommendations for diagnosis of osteoarthritis state that although specific aspects are defined for each joint, a confident diagnosis may be made according to symptoms like pain, stiffness, and functional limitation, and signs on examination like crepitus, restricted movements, and bony enlarged or deformity. Plain radiograph provides a morphological assessment of osteoarticular changes, and occasionally other investigation may be considered for the diagnosis of atypical situation or to exclude other possible conditions. Diagnosis of osteoarthritis will depend mainly on plain radiographs. What plain radiograph demonstrate? It demonstrates joint space narrowing, the presence of osteophytes, bone cysts, subchondral bone sclerosis. Radiographs are cheap and are easily available. They are not a good measure for disease progression, as this is based on measuring the joint space narrowing, which occurs at 0.1 millimeter per year. So it is difficult to measure accurately, but several radiographic score systems have been employed to assist the measurement of osteoarthritis progression. The presence of osteophyte had a very strong association with knee pain, whereas the absence or presence of joint space narrowing was not associated with this condition. Knee pain severity was a more important determinant of functional impairment than radiographic severity of osteoarthritis. ده طبعا البلين راديوجراف هنا demonstrate joint space narrowing, and here is a plain radiograph of the knee joint with joint space narrowing. Here is the presence of osteophyte. Here is the subchondral bone sclerosis and subchondral bone cysts. This is also the Killian and Lawrence scale for osteoarthritis, which divided into grades according to the narrowing of the joint space and the presence of osteophytes. Normal phase, no features of osteoarthritis. Doubtful, where there is a minute osteophytes, but there is a doubtful significance. In mild cases, this is a definite osteophyte, but with normal joint space. Moderate, there is a moderate joint space narrowing like this, and the severe cases, this is a marked narrowing of the joint space with subchondral bone sclerosis, but apparent in K and L grading of severity of knee osteoarthritis is gradual narrowing of the joint space. This is also a plain X-ray of different stages for osteoarthritis. Here is the osteoarthritis of the knee joints with normal knee joint, and here is a narrow joint space and the presence of bone spur. and here is a normal hip joint, and here is a narrow space, narrow hip joint, which is the space between the head of the femur and the acetabular cavity, and here is the bony spurs indicate osteoarthritis of the hip. This is a hand, or what is termed nodal osteoarthritis, with osteophytes present here, and here is the narrowing of the joint space due to cartilage loss. This is a normal joint or normal space, but here is the space of narrowing, narrow joint space, and presence of marginal osteophyte. Other plain X-ray, we can do magnetic resonance imaging. This is already well established for the use in assessing ligaments and meniscal tear in the knee. It has no place in routine clinical assessment of osteoarthritis, but may be specific and sensitive way of quantifying cartilage loss. Currently, magnetic resonance imaging has not proved to be sensitive enough in the detection of preclinical osteoarthritis. Computed tomography or CT scan is thought to have little advantage over plain X-ray unless an axial joint view is required. Musculoskeletal ultrasound is good in assessing cartilage integrity and destruction, but in most weight-bearing joints, cartilage is not easily accessible. Radionuclide imaging is considered inadequate in assessing disease progression as it lacks sufficient anatomical detail. Retention of technetium-labeled diphosphonate in knee predicts subsequent cartilage loss in patients with advanced osteoarthritis. What about biochemical markers in osteoarthritis? طبعا molecular markers may theoretically be able to detect osteoarthritic changes at an early stage. There are currently several candidates for biochemical markers in osteoarthritis, but none have been found to be specific. They reflect remodeling of bone, cartilage, and synovium. What are biochemical markers? Including cartilage oligomeric matrix protein, may be a marker of cartilage destruction. C-reactive protein, hyaluronal, YKL40, and metalloproteases are markers of synovial inflammation. Pyridinoline and bone sialoprotein are markers of bone turnover. Another way for diagnosis of osteoarthritis is examination of the synovial fluid, and we comment on examination of the synovial fluid on different items, including volume, clarity, color, viscosity, white blood cell per microliter, polymorph nucleoleucocyte percent, and the cartilage and culture. In examination of the synovial fluid, we detect here the category of osteoarthritis. It located in the inflammatory category. Inflammatory, we have inflammatory, non-inflammatory, normal, and septic arthritis. And on examination, we differentiate between these different types. And in type of osteoarthritis, which is termed a degenerative pattern of osteoarthritis, the category concerning with it is the non-inflammatory. In non-inflammatory, we have a volume less than 3.5, clarity is transparent, color is yellow, high viscosity, white blood cell count from 200 to 2000, polymorph nucleoleucocyte usually less than 25%, and the culture is negative. يبقى what we concern here in synovial fluid analysis is the pattern of non-inflammatory arthritis, or what is termed degenerative arthritis, which is concerned with osteoarthritis. Treatment of osteoarthritis, we have non-pharmacotherapy, including reduced load on the joint, exercise, correction of malalignment, reduce load on the joint, including avoid unnecessary stress, increase muscle strength, use of walking stick, and weight loss. The goal of treatment of osteoarthritis include alleviation of pain, improvement of functional status. Optimally, patient should receive a combination of non-pharmacologic and pharmacological therapy. What about the non-pharmacological therapy? They are the cornerstone of osteoarthritis therapy, include education of the patient, heat and cold compresses, weight loss, exercise, physical therapy, occupational therapy, and unloading in certain joints. What about the physical activity? One of the most beneficial way to manage osteoarthritis is to get moving, which is considered as important part of the training of the treatment plan. Weight management, excess weight add additional stress to the weight-bearing joints such as the hip, knee, feet, and the back. Weight loss and general exercise program should be encouraged for all patients with knee and hip osteoarthritis. Assisting device can help to improve function and mobility. These include items such as canes, walkers, or splints. They can unload the affected joint like the hip or the knee joint and diminish pain during walking. Quadriceps stretching or strengthening exercises build the muscle around the affected osteoarthritic knee joint, easing the burden on those joints and reducing pain and joint stiffness. Stretching, طبعا slow and gentle stretching of the joints may improve flexibility, reduce joint stiffness and joint pain. Pulsed electromagnetic field therapy and transcutaneous electric nerve stimulation are of short-term benefit. Nature or alternative therapies, many people with osteoarthritis use nature or alternative therapies to address symptoms and improve their overall well-being. This include nutritional supplements. Other therapies in osteoarthritis include acupuncture or acupressure, joint massage, muscle relaxation exercises, and the use of hydrotherapy. American College of Rheumatology guidelines for the management of osteoarthritis of the hand, hip, and the knee was recently reviewed. Pharmacological modalities recommend for the initial management of patients with osteoarthritis include acetaminophen or paracetamol, oral or topical non-steroidal anti-inflammatory drugs, tramadol, intra-articular corticosteroid injection, glucosamine, chondroitin sulfate, and other nutritional supplementation. Intra-articular hyaluronate injection, duloxetine, and opioids are conditionally recommended in patients with inadequate response to initial therapy. Surgical procedures are advised in patients with long course of the disease and or untreatable pain or disability. Surgical options including lavage, debridement, correction, osteotomy, and arthroplasty. Pharmacological treatment بقى including analgesics and anti-inflammatory drugs. Begin treatment with acetaminophen or paracetamol for mild or moderate osteoarthritis, pain without apparent inflammation. If the clinical response to acetaminophen is not satisfactory or the clinical presentation of osteoarthritis is inflammatory, consider the use of non-steroidal anti-inflammatory drugs in patients with highly resistant pain. We consider the analgesic tramadol. Non-steroidal anti-inflammatory drugs as a line of treatment, they are the most commonly used drugs to ease inflammation and relieve pain. This include aspirin, ibuprofen, naproxen, celecoxib. In patients with elevated risk of gastrointestinal toxicity from the use of non-steroidal anti-inflammatory includes the addition of a proton pump inhibitor like misoprostol for the treatment of this condition. Selective cyclooxygenase inhibitor like celecoxib instead of a non-selective non-steroidal anti-inflammatory is preferable to ease or to lowering the effect on the gastrointestinal tract. Hydroxychloroquine, which is approved in treating rheumatoid synovitis, has been used but off-labeled in patients with hand osteoarthritis. Duloxetine or Simpalata, the selective serotonin non-epinephrine reuptake inhibitor. Duloxetine has been found to be effective in treating osteoarthritic pain. However, duloxetine was also associated with significant more nausea, dry mouth, constipation, fatigue, and decreased appetite. Glucosamine and chondroitin sulfate administered orally and is used to relieve musculoskeletal symptoms. Many preparations are available, but some of which also contain chondroitin sulfate. Both glucosamine sulfate and chondroitin sulfate are derivatives of glucosaminoglycans found in articular cartilage. We have another line of treatment is topical cathepsin cream, which is often used on hand or knee in patients with moderate pain in osteoarthritis. ده اللي هو البروسيجر اوف intra-articular injection of corticosteroids. طبعا not more than 3 to 4 times in a single joint per year, because long-term damage to articular cartilage and increased risk of localized osteoporosis can occur. Biomechanical treatment, the aim طبعا of biomechanical treatment is to identify biomarkers of bone and cartilage turnover that may identify those at risk for osteoarthritis and therefore prevent further disease progression. Future directions طبعا includes the use of biological therapies including osteoserine or diaserine, which is an anti-interleukin-1, is a drug that inhibits the production of activity of metalloproteinases and interleukins and may have an effect in delaying progression of hip osteoarthritis and prevent cartilage degradation. Infliximab or Remicade or anti-tumor necrosis factor alpha also prevent cartilage degradation. We have a surgery including arthroscopic debridement and lavage can improve symptoms in degenerative meniscal tear but does not prevent disease progression. Osteotomy in early osteoarthritis may relieve symptoms and slow the rate of progression. Arthrodesis is good as a last result for pain relief. It can be used in carpal bones, spine, and foot. Joint replacement is the final solution for many people, providing pain-free functional improvement in the affected joints. We have update in the treatment of osteoarthritis, including mesenchymal stem cells are an investigational treatment for osteoarthritis. Placement of mesenchymal stem cell into the knee joint has proved an effective treatment for osteoarthritis. Bone marrow makes this type of cells. They can grow into new tissues, including cartilage. By gathering these cells and injecting them again into the joint space, the hope is that they will give rise to a new cartilage and reduce inflammation. Hyaluronic acid or hyaluronate injection, also called viscosupplementation. This treatment tries to restore synovial fluid, which is a slippery substance that helps to lubricate joints. A major component of synovial fluid is called hyaluronate. Many trials to restore mobility and improve joint space by injecting hyaluronate injection into the joint space. Several preparations are available, either low hyaluron or high molecular weight, including Synvisc. A platelet-rich plasma injection. In this treatment, a sample of blood is taken and spun in a machine called centrifuge to pull out the blood platelets and the plasma. When injected back into the joint, this super concentrated mixture contains substance that could promote healing. Bone marrow aspirate concentration, cells are taken from the body and use them to stimulate the healing process inside the knee. The advantage is bone marrow may be easier to obtain than mesenchymal stem cell bone marrow cells differentiate into fibroblast and fat cells, and also contain other substances involved in promoting cartilage regrowth and reducing inflammation. Autologous cultured chondrocyte, this is a procedure to repair injuries which can lead to osteoarthritis. It involves collecting of cells that form cartilage from joints, growing the cells in a laboratory, and then injecting these cells again into the knee joints. And thank you.